everybody can hear me. All right, so today's e-class session is on ECG quiz based on the ECGs which we have already learned in the previous e-class sessions. Essentially, the quiz is going to be a discussion on the traces pertaining to pediatric arrhythmia as well as some of the basics of pediatric electrocardiology. So let's start with the first of the ECGs in this e-quiz session. All right, so this is the ECG. I believe you can see it very proper, all of you there. If there is any problem, you people can put up a message on my desktop. So let me give a very brief detail about this baby who is a 2.5 years old baby who has recurrent palpitations, hemodynamically compromising. Before I put up the questions on this ECG, let me guide you through the ECG here. What you can see here is a regular narrow Qrs tachycardia, quite rapid. The rate is about 300 beats per minute. The Qrs complexes in the precordial leads, they are in concordance with the age of the patient, so there is no abnormality there. So this is a regular narrow Qrs tachycardia, rapid, and then I will bring your attention to one specific feature of this ECG, and that is, look at the T waves. The crown of the T wave is abnormal. And the nadir of the T waves in inferior leads is also abnormal, meaning you have a P wave superimposed on the T wave. I believe this point is clear to everybody. So regular narrow Qrs tachycardia where the T waves are seeming to be abnormal, one should consider the P waves are falling onto the T wave, thereby indicating is a long RP tachycardia. So in a pediatric population, if you have this kind of an ECG, which is a rapid regular narrow Qrs tachycardia, a long RP tachycardia, what are your thoughts about the commonest of the diagnosis? Is it atrial tachycardia? Is it PJRT? Is it AVNRT or is it AVRT? Can I see the response of the people? Kunika, is it possible for me to see the response? No? Excuse me? So Narendra Deva, he said AVRT. Anybody else? It's not a bad differential diagnosis, but my question was, which is that tachyarrhythmia? I give you some of the brief description in the history. Incessant tachyarrhythmia in the pediatric age group, which is a long RP tachycardia. The diagnosis is indeed PJRT and not AVRT. AVRT is characteristically paroxysmal, whereas PJRT, as the name itself suggests, it is a persistent junctional reciprocating tachycardia. If you have a baby who has incessant tachyarrhythmia, which you think on the basis of the ECG is a long RP tachycardia, leading to hemodynamic compromise or cardiomyopathy, unless proved otherwise, such a long RP tachycardia should be considered as PJRT, and hence the diagnosis here is PJRT. Now let us look at some of the characteristics of this tachyarrhythmia, which is evident here in the Holter monitoring and the rhythm strips. You notice here that the baby is almost always in tachyarrhythmia in this format. There are hardly few sinus beats, but these sinus beats actually fetch the diagnosis. And how is that? Look at this combination here of narrow Qrs complexes occurring at a relatively rapid rate. What you notice here is that a normal looking PQRS followed by the T which is abnormal. And consistently you would notice that it starts that way. That simply means this particular P wave is related with the previous QRS. and then that RP interval is longer and the tachycardia starts. So consistently a tachyarrhythmia starting in such a way connected to the previous normal looking QRS, and if it is persistent and also the tachycardia terminates with another abnormal looking P wave, that means there is a P wave, on top of that. So a tachycardia which terminates with a P wave cannot be atrial tachycardia. Similarly, a tachycardia which starts with a P wave superimposing on the T consistently associated with a normal looking QRS means this is an orthodromic tachycardia using an accessory pathway, and the VA conduction, that is the retrograde conduction across the pathway, is delayed. So a PJRT is an orthodromic tachycardia, uses an accessory pathway only in the retrograde direction, and this accessory pathway is characterized by slow conduction. Hence, if you have a baby, persistent narrow QRS tachycardia, rapid rates, cardiomyopathy, P wave looking abnormal, indicating there is a P wave, is almost always PJRT. This tachycardia could have been also AVRT if it is not such persistent but paroxysmal. So there is a subtle difference between PJRT and the AVRT in the pediatric arrhythmia. Let's talk about another pediatric tachyarrhythmia. How is this tachyarrhythmia, and then what could be your diagnosis? Let me lead you to some of the characteristic features of this tachyarrhythmia. It's a very, very narrow QRS tachycardia. In accordance with the age of the patient is about again under 2 years baby. What you notice here is extremely rapid tachycardia. And then if you notice the rhythm strip in lead 2, you will see more QRS complexes than the so-called T waves, and these T waves being abnormal, you can always consider that there's a P wave falling onto that. So you are dealing with a tachyarrhythmia where there are more QRS complexes than P wave, and then I'm saying it's a pediatric age group. So with these features, my question to you is, what is the commonest diagnosis? Is it atrial tachycardia? Is it a junctional ectopic tachycardia? Is it an AVNRT or is it AVRT? So I would ask some of the participants to respond. Yilkal Chani says it is B. Perfect. The answer is JET. For simple reason, and that is, in an atrial tachycardia, you could have had as many QRS complexes as there are P waves. But in an atrial tachycardia, it cannot be less P waves than the QRS. So atrial tachycardia is out. AVNRT occasionally is associated with AV block with more P waves than the V. Extremely rarely, AVNRT is also possible when there are more QRSs than the P waves. Extremely rare, usually seen in adults with some degenerative disease affecting the AV node. But we are talking about a pediatric age group. So AVNRT is out of the context. We know that the AVRT, that is atrioventricular reciprocating tachycardia, requires both atrium and the ventricle, and they got to be essentially 1:1 relation. And hence, the diagnosis is not atrial tachycardia because there are less P waves. AVNRT in a pediatric age population is never associated with AV block. In an AVRT, you should essentially have as many P waves and the QRSs, and then the P and the QRS relationship has to be normal. And hence, if you see in a baby who has got a narrow QRS regular tachycardia, but there are less P waves than the QRSs, unless proved otherwise, or it is almost a diagnostic of junctional ectopic tachycardia. More often seen post-operatively, but occasionally it is also seen de novo. Let's go to quiz number 3. In another tachyarrhythmia in the pediatric age group. So again, I guide you people, help you to make the diagnosis. A relatively slower tachycardia than what you saw in the last 3 ECGs. The common factor here still is narrow QRS tachycardia. A closer look at this tachycardia would reveal that this tachycardia is irregular. So you are dealing with a pediatric tachycardia where it is irregular and the irregularity is irregular. It's an irregularly irregular narrow QRS tachycardia in the pediatric patient. I will bring your attention to one more finding here, and that is you see P waves. And these P waves are more than the QRS. So a baby who has irregularly irregular narrow QRS tachycardia, if the P waves are not to be seen, it could have been easily atrial fibrillation, one of the rare pediatric tachyarrhythmia. So now with this background, I will put up the question. Is it atypical AVNRT? Is it PJRT? Is it atrial tachycardia? Or is it AVRT? So I would like to see some response. Vimala Rani says it is C, atrial tachycardia. She is perfectly correct. So if you have a irregularly irregular narrow QRS tachycardia, if the P waves are not seen, well, it becomes atrial fibrillation. And if you see the P waves, then it has to be atrial tachycardia, especially when you see the PR interval is changing. Some P waves are associated with the QRS. The association of the P and the QRS is actually varying. This PR seems to be shorter and this PR seems to be longer. And some P waves are unaccompanied by the QRS, meaning this is an atrial tachycardia where the P to P interval is almost constant. P, a P, a P, a P, a P. So the P interval is constant, whereas the PR interval is changing, and sometimes the P wave is unaccompanied by the QRS complex. So this tachyarrhythmia, irregularly irregular narrow QRS tachycardia, more P waves than the QRS, should be considered as an atrial tachycardia with varying AV conduction. You people can also put up some questions in case if you have anything in your mind. Venu J says it could be ventricular with AT. That's perfect. That's more scientific way of what I just now said. So this could be very well be described as an atrial tachycardia with the AV ventricular conduction pattern. Perfect. So we go to the next ECG. Another pediatric tachyarrhythmia. What you notice here, unlike the previous tachyarrhythmia, is that the QRS tend to be little wider than the previous ones. It's also associated with rightward axis. You will see that the lead one shows the negative complex. AVL shows the predominant S waves. So you are talking about a tachyarrhythmia in a baby, right bundle branch block pattern with a discordant axis. Oh no, it's not really a discordant axis. It's a right bundle branch block with the rightward axis. So what could be your diagnosis? I am going to be giving you some choices here. The choices are AVNRT, junctional ectopic tachycardia, AVRT, and a ventricular tachycardia. Narendeva, I think you are very smart in reading ECG and you have appropriately picked up the right answer, and that is ventricular tachycardia. Can I ask you one question? What made you think it is ventricular tachycardia? Narendev, because we did not discuss VT in the last few ECG, is that excellent? Narendeva told about fusion and the capture. Excellent. So whenever you have a wide-looking tachycardia, try to find out which of the QRS complexes does not really belong to the major group. Narendra picked up one beautiful phenomenon here, and that is this complex. He also picked up another complex here. He probably picked up another complex here. So what essentially this complex is, it is a kind of a fusion complex which is not as wide as this and not necessarily too very narrow. What is essential to define a fusion or a capture complex is that it has to be essentially be preceded by a P wave, which may or may not be seen very obviously. But if you look carefully here, looking at the this T wave versus this T wave, you are noticing that this T wave is different from this T wave because there is a P wave. So this P wave has an opportunity to go across the AV node and capture the ventricle. So resulting either the fusion or the capture. So excellent, Narendra. So you made the correct diagnosis. You said it is a wide QRS tachycardia, which is regular, and these wide QRSs are sometimes looking narrower, thereby defining that as a fusion or a capture beat, which is a diagnostic manifestation of a ventricular tachycardia on ECG. Excellent. So wide QRS tachycardia, some of the QRS complexes not belonging to the major family members in the form of narrower or very narrow QRS, defining that to be a fusion or a capture complex. Hence the diagnosis is VT. We go to quiz number 5, another pediatric tachyarrhythmia. I will describe a few of the features so as to make your job easy. Again, rapid, regular, narrow QRS tachycardia. The QRS complexes are in accordance with the age of the patient, which is about 3 years. You will notice that narrow QRS, and then the T waves do not seem to be really very abnormal. There is probably no indication of a P wave falling onto the T, and I am finding some difficulty in figuring it out where there are P waves. So you have a pediatric tachyarrhythmia, regular narrow QRS tachycardia, very rapid, which is paroxysmal, where you are not really finding a typical P wave. So what could be your diagnosis? Is it AVNRT? Is it JET? It is AVRT or VT? I am asking which is the commonest diagnosis or the most probable diagnosis. Venu says AVRT, which is incorrect. So we are left with the 3 more choices. Excellent. Narendra says AVNRT, and Vimala says AVNRT. Perfect. The reason being, you have a regular narrow QRS tachycardia where you are finding difficulty in identifying the P waves. That simply means it may be inside the QRS complex. A closer look at the QRS complexes, especially in say lead V1, you would notice that soon after the QRS, there is some deflection. The QRS and there's a small deflection. QRS and small deflection. Look at the AVR. It is typically the so-called R dash is more prominent. Look at lead 2. It seems like the S wave is little more prominent. So if you have a regular narrow QRS tachycardia, which is paroxysmal, either it is in the pediatric age group or in adult, most often the diagnosis could be AVNRT. Somebody said the diagnosis of AVRT. AVRT typically is associated with, if not very remarkable, but subtle P waves falling onto the ST segment, resulting in an ST segment depression. Here, one negative point with respect to AVRT is no significant ST segment depression. If you have in a pediatric tachyarrhythmia, significant ST segment depression, which is paroxysmal almost always the diagnosis is AVRT. But this ECG is a regular narrow QRS tachycardia, no significant ST depression, no obvious P waves, but the P waves can be dug out from the QRS complexes, which are seen. If you have that in your mind, the so-called tiny P waves is seen at the end of the QRS. So the diagnosis most probably in this is AVNRT. Whenever you have a suspicion about whether there is a P wave there or no, if you have a 12-lead ECG, it makes sense to compare. For example, this is a sinus rhythm 12-lead ECG of the patient. Look at the V1. There is a smooth transition of the QRS and the ST segment. What I mean is the J point here is not well defined. It is smooth. Come to the V1 here. The J point is not as smooth as this, thereby indicating that there could be the P wave. Come to the AVR. AVR, the so-called R dash pattern in AVR is not as prominent as in this AVR during tachycardia. Thereby, this so-called R dash is a retrograde P wave. This so-called R dash in V1 is a retrograde P wave, a regular narrow QRS tachycardia. Paroxysmal P waves are not really very clearly seen, but only with the difficulty could be dug out from the QRS complex. Compare with the sinus rhythm ECG, where the J point is not very significant, but during the tachycardia it is significant, is almost a diagnostic of AVNRT, not necessarily in the pediatric age group, but even in adults. But AVNRT among atrial tachycardia, AVRTs and PJRTs and JET, AVNRT is the least common tachyarrhythmia in the pediatric age group. Let's now look at some other ECGs belonging to babies. I bring your attention to the rhythm of this ECG, which is sinus rhythm, because you have got typically nicely looking P waves preceding the QRS complexes. Go through carefully, you will notice that at times the PR interval, especially in some leads, they are very, very short. Look more carefully, you start looking at the delta waves. So essentially, it seems to be short PR during sinus rhythm with the delta waves. With this background, I am going to be putting up some questions for you. This ECG pattern is suggestive of septal accessory pathway. This ECG, if you see, you should rule out congenital heart disease. If this ECG, you would, Srinivasan Narayanan is in a hurry. He has to go to the cath lab. Srinivasan, I know. Let me read up the options here, Srinivasan. Okay, so to begin with, you have this pre-excited sinus rhythm ECG. After looking at this ECG, should we consider this as a septal accessory pathway? Should we really look at in this baby, is there any congenital heart disease? Should we presume that this baby, if gets into tachyarrhythmia, it is most often narrow QRS tachycardia? Is it all of the above? Srinivasan, now, what do you say? Nobody? Srinivasan already ran away? Ilkal Chani. Srinivasan, why did you change your decision? Cath lab is not ready. All right, so most of you, Sundar, Srinivasan, and other person, you all called it as all of the above. That's correct. So the reason why I put up this ECG is we should remember that in the pediatric age group, the commonest tachyarrhythmia is associated with an accessory pathway. Rarely the accessory pathway is manifest as this is seen, because most of the pathways are leftward, left-side accessory pathway, and hence the pre-excitation is not obvious. That's the point number one. Even in a patient who has, during the sinus rhythm, a pre-excitation pattern, most often the documented tachyarrhythmia is going to be a narrow QRS tachycardia. This is an important point I want you people to remember. Most often, accessory pathway mediated tachycardia are narrow QRS tachycardia, irrespective of whether during the sinus rhythm there was pre-excitation or no. So this is one of the correct statements. In the pediatric, especially in the pediatric age group, if you have seen a pre-excitation, you should essentially rule out a congenital heart disease. The commonest of them, I think you know, is an Epstein's anomaly. Whenever you see a pre-excitation pattern, the first thing I believe should be looked at the transition from the V1 to V2. If you have a transition, here it's a negative delta or a QS complex suddenly becoming R wave, meaning it's a septal accessory pathway. Most often the septal accessory pathways are right posterior septal accessory pathway, and then if you look at the inferior lead, you will notice that the negative deltas in 3 and AVF. So these negative delta waves in inferior leads and the transition in V2 suggests it is septally located, posteriorly located, and the statistics say that such an accessory pathway is usually located on the right posterior septal side. So among all these options, all the options are correct. We go to another basics of electrocardiology. On the left hand side, I have shown you the vector going towards the electrode, which is recording and giving you the complexes on the surface ECG. Look at carefully the direction of vectors and the possible recording what you get from that electrode. And my question is, as recorded by the electrodes, pick the correct combination. Is this the right combination? Combination 1, combination 2, combination 3. So which is the right combination? Narendeva, smart. Srinivasan, smart. Avinash and RK, all of you people are smart. So the basics of electrocardiology is that a vector, when it goes towards an electrode, it has to essentially record a positive complex. If the vector goes away from a recording electrode, it will have a negative complex. Here it is positive, it's a wrong combination. A vector going towards a recording electrode, it has to essentially have a positive QRS complex. A vector which goes towards and then away should record initial R, and when it is going away, later negative complex. So combination number 3 is correct. This is so very essential in understanding the electrocardiology, especially when you are looking at the QRS morphology and finding out how is the ventricular activation pattern or an atrial activation pattern, and this actually decides the axis and makes your diagnosis easy. So I really am talking to smart people there. Let me assess the smartness of you guys further. Well, two very basics. Which one of the following is incorrect? Lead 1, does it utilize the right atrium and the left atrium electrodes? Lead 2, does it utilize the right atrium and the left leg electrodes? Lead 3, does it involve right leg and left lower leg? Or left lower leg always is a negative electrode? Which one of the following is incorrect? I thought it is quite simple. There will be rapid. Srinivasan. C. Lead 3. Vimala. C. So I will repeat which one of the following is incorrect. Sundar says B. Hilkar says C. So many people picked the right answer, and that is lead 3. Which is incorrect. Left lower leg is always a negative electrode. So this is actually shown in the red. It is always negative. The right arm, the lead one, the right arm uses Right arm as negative, left arm as positive. In lead 2, left arm electrode is negative and the left lower leg is positive. Lead 3 is a wrong combination, which is right leg and the left lower leg. So we go to quiz number 9. I have given you combination here. Lead 1 shows in A positive, in B positive, C negative. Similarly, lead 2 in A, B, C. Now my question is, right axis deviation is shown by which of the columns? Vinu and Srinivasan say it is column C. Sundar says C. Every one of you said it correctly. If you have a negative complex in lead 1 and positive in lead 2, 3, it has to be away from the lead 1 and then it has to be in the right axis, the right quadrant. And hence, this is right axis deviation. So, I'm really giving you a very simple quiz today. I think another simple picture here. Look carefully. What I'm showing is the ventricular activation pattern. I'm putting up 2 electrodes. This is V1. This is V6. I'm giving you the initial part of the ventricular activation as recorded in V1 and in V6. Now, this initial part of the ventricular activation, does it detect the normal way of conduction, or is it indicative of RBBB? Is it indicative of LBBB, or is it an abnormal conduction in the form of a ventricular ectopy? Narendeva, everybody, 3 of them said A. Excellent. Excellent. Is it that you people are smart, or did I actually teach the ventricular activation pattern very nicely in the beginning? The choices are A and B. A means I had taught you people well in the past. B, no, it is your own intelligence. Thank you, Vinu. Vimala, thank you, thank you. I am forcing Avinash and RK also to say thank you. Thank you. You people have made my day. At the same time, it is such a pleasure to be talking to you smart people there. Excellent. See, this is so very essential in understanding the electrocardiology, especially when you are dealing with bundle branch blocks, etc. The initial ventricular activation is so very important to understand. I don't think I should be going too many things about this picture because you already know. The so-called tiny Q wave is a subtle activation. As long as you see in your QRS complexes, in the V6, a tiny Q and a tiny R in V1, you can be almost certain that the conduction in the initial part of the ventricular activation is normal, and hence it is extremely unlikely there is an associated accessory pathway. It is extremely unlikely that that QRS complex is because of the ventricular ectopy. So very essential in understanding and so very essential in making a quick diagnosis whether the QRS is the result of a normal conduction or an accessory pathway or a bundle branch block or a ventricular ectopy. What you got to be simply looking at is in V1 and V6 and the initial 30 to 40 milliseconds of that QRS complex. It makes life so simple, and hence I put up this ventricular activation pattern. Great. So do we have time for some more? I believe yes. So we go to another quiz here. This ECG belongs to an asymptomatic 5-year-old baby boy. It is an incidental detection. Please look at this carefully. I will bring your attention to some of the characteristic features of this ECG. And what is that? Fairly regular narrow QRS complexes. What we notice here that the T waves are changing. So we know already made the diagnosis before I could actually give some options. So you remember that if T waves are looking abnormal, always consider that the T is falling onto that. Simple. So that is why we thought you have regular narrow QRS complexes and T waves are looking abnormal. So we thought there can be a P wave, and if you consider one P wave and a one P wave and a one P wave, essentially it seems like there are two P waves and a QRS complex. So we made the diagnosis of 2:1 AV block, but I would say that is wrong. So you have got some more choices here. First degree AV block, second degree type 1 AV block, which is Ventricular phenomenon. Second degree type 2 AV block, as we said, it is 2:1 AV block, which I already said wrong. Sundar, I'm telling you it is wrong. Vimala. Srinivasan Narayanan, makes the diagnosis of CHB. Srinivasan, is it because many people made the wrong diagnosis and that is why he said CHB? Or tell me why you think it is CHB? I think one of those days, I have insisted that in a person, if you think it is a 2:1 AV block, most often it is CHB. That I'm sure you remember. In addition to that, I have told something else, which almost proves that indeed it is not 2:1 AV block, but it is CHB. Srinivasan, can you hear me? It is extremely unlikely for a 2:1 AV block to be type 2 AV block. I want you people to remember this. On top of that, there is something very interesting in this ECG which tells you this is not 2:1 AV block. Srinivasan, are you still there? Can you just give your comment? What were the points why you thought it is CHB? I am telling you that you are right. Atrial rate more than ventricular rate that is why we are talking about AV block. But my question was why it is CHB? Okay, so let me come back to PP interval regular is the characteristic feature of any kind of an AV block. PP interval is regular in first degree AV block, it is second degree type 1 AV block, second degree type 2 AV block. This is not a classical feature of CHB alone. Srinivasan, you have forgotten another one. Okay, let me tell you people. Next time, whenever you see a 2:1 AV block, and if it's typically associated in the pediatric age group and the narrow QRS, it is extremely unlikely that it is 2:1 AV block, it is CHB. The reason being, if you look carefully, the PR interval, look at this PR, look at this PR, look at this PR, look at this PR. What is happening with the PR intervals? The PR interval is classically it is changing. Excellent. Vinu picked up the nice point. The PR interval is changing. If you have correct, Vinu further defines this as a congenital CHB, and that is because of the narrow QRS. But the question was, why it is a CHB? You should consider all 2:1 AV block in the pediatric age group, unless proved otherwise, CHB. The further documentation can be done on the basis of the PR interval. The PR interval, if you think it is changing, is almost a diagnostic of CHB. It is just that it's a coincidence that the rate is approximately half the atrial rate, and that is why there is an obvious or near obvious 2:1 conduction pattern. but because the PR interval is consistently changing in the presence of a 2:1 AV block, we should consider this as CHB, which is more often documented if you have a patient and take a longer rhythm strip, or if you subject this baby for a Holter monitoring or event monitoring. Classically, you would notice that the PR interval would change, and at times you will see that there's a clear CHB. So very quickly, I will revise what I said. If you see 2:1 AV block in a pediatric patient, it is most often CHB. If it is a narrow QRS, it is almost always a congenital CHB. If you also have, in addition to 2:1, seemingly 2:1 AV block, a narrow QRS, but the PR interval is characteristically varying, it is diagnostic of CHB. If the baby does not have congenital heart disease, if the baby is hemodynamically stable, and if you have seen that during crying or during physical exercise, the rate is improving, you do not have to do anything for this baby. Well, I think this is the further rhythm strip of the same patient. You will notice that this PR is longer and this PR is shorter. And the very fact that the P waves are falling onto the T wave, resulting in different morphologies of the T waves, itself means that the RR interval or the PR interval is changing. So, another feature of a congenital CHB, in addition to so-called 2:1, is the PR change and the T wave morphology changing from beat to beat, almost diagnostic of CHB. And then if you have narrow QRS, it's congenital CHB. If it's asymptomatic, structurally normal heart, please don't advise permanent pacemaker for the baby. So we are going for the last of the ECG today. 6 years, Manju, whom we saw in the year 2005, and still, it is still interesting. That's why I put it here. We'll have a look carefully here. I do not want to further tell you something more about this. Narrow QRS complexes, there are indeed P waves. And if you look at the QRS complexes, each QRS complex is preceded by a definite P wave. And whenever you are seeing the P wave and the QRS, the PR relationship seems to be constant. With this background, I put up the questions. I think everybody is, thinking about going back to their work. I did not get any of the answers before I put up. Wow, Vinu, excellent. Sundar, excellent. Great. So the choices, if I put hyperkalemia, hypercalcemia, well, it's wrong, because hyperkalemia and hypercalcemia tend to actually cause ST segment shortening with predominant tall T waves in hyperkalemia, hypercalcemia. Hypothermia is Sundar's diagnosis. Sundar, tell me, what is one feature apart from the long QT you should have expected to be very classical of hypothermia? Hypothermia is typically associated with bradycardia. Hypothermia is associated with what Srinivasan says is an Osborn wave. Osborn wave is defined as a J-point abnormality, which actually says that the latter part of the QRS complexes have a notch. Typically, at the S wave, you will have a notch. So that is very characteristic of hypothermia. This rate cannot be hypothermia, and there is absence of Osborn wave. It is extremely unlikely that, so brady is not there, that is a point against hypothermia. And the hypothermia indeed can cause QT prolongation, but that is an extreme hypothermia. I do not think it is ever documented without an Osborn wave QT prolongation, and hence hypothermia is not the answer. So none of the above is the correct answer, and most of you had actually made the correct diagnosis, and that is the long QT syndrome. This long QT syndrome, well, we have not done the genetic analysis, but you would notice that it is typically associated with the long ST segment. It is actually a type 3, one of the rare but malignant long QT syndromes. The baby is with the device, has undergone even a device change for the battery replacement. So this is a long QT syndrome, and the feature suggests that most probably it is type 3 long QT syndrome. So ladies and gentlemen, thank you for being around with me. It was fun for me. How about you? So thank you very much, and so if there are any questions, I'm here for another 2 minutes. All right, so you all people have a great day. Go back to your workplace, and I meet up with you next month, one of the Thursdays. Thank you, and thank you, Kunika, as well.